Good evening, everyone. Welcome to the April edition of the Scleral Education Society's webinar series. My name is Dr. Ashley Tucker. I will be your moderator for this evening. I'm so excited to introduce four amazing cornea and contact lens residents from across the country. This is our first ever cornea and contact lens resident grand rounds webinar series. So I'm again excited to introduce all four of them. I'll give you a brief biography for each one of them so you can know a little bit about them before they give their poster presentation. So Dr. Matthew McGee earned a Bachelor of Science in Biology from the University of Missouri, also known as Mizzou. Dr. McGee then earned a Master of Arts in Biomedical Science and a Doctor of Optometry degree at Chicago College of Optometry, Midwestern University, graduating with several academic and clinical honors, including the AAOF Johnson & Johnson Award of Excellence in Contact Lens Patient Care. Dr. McGee is also a member of Beta Sigma Kappa International Optometric Honor Society and Gold Key International Optometric Honor Society. He is currently completing a residency in cornea and contact lens with an emphasis in ocular disease at The Ohio State University Wexner Medical Center, Havner Eye Institute. Dr. Janna Pham is currently a resident of cornea and contact lens at the University of Houston College of Optometry. She completed her undergraduate studies at the University of Texas at Austin and graduated from the University of Houston College of Optometry. Dr. Travis Pfeifer is the cornea and contact lens resident at the SUNY College of Optometry. He has a strong interest in education, research, and writing within the field of specialty contact lenses. And last but not least, we have Dr. Valery Medina, who graduated from San Diego State University in 2017 with a Bachelor of Arts in Biology. While living in San Diego, Dr. Medina helped coordinate free monthly vision clinics in, maybe Tecate, Mexico. Dr. Medina earned her Doctor of Optometry degree at UC Berkeley College of Optometry in 2023. She was awarded the Dr. Robert B. Mandel GP Clinical Excellence Award, and Dr. Medina is currently completing her fellowship in medical contact lenses and anterior segment ocular disease at the Casey Eye Institute at Oregon Health and Science University. They have no financial disclosures. So just a couple more housekeeping things. If you've joined us before, you are very aware that you have to be on the webinar for at least 50 minutes for COPE credit. So please make sure you're on for that amount of time. We strongly encourage you to ask all the questions that you would like. We would really appreciate it if you put the questions this time in the Q&A feature. It's just easier for us to manage. And since we have four speakers, if you can keep up with which speaker you would like the question addressed to, that would make it a lot easier for us at the end. For COPE credit, please make sure, or one of the options for COPE credit is to make sure that you download the OE Tracker app in the Apple App Store or Google Play Store. It's very straightforward. At the end of the presentation, we'll have a QR code. You just open the app, make sure all of your information is there, scan the QR code, and then you'll get an instant confirmation. You do not have to do this option. You will automatically be getting your CE certificate within 2 weeks, but this is a very easy way to get COPE credit. All right, Dr. Pfeifer, it is all yours.
Thank you so much, Dr. Tucker. So again, I'm Dr. Travis Pfeifer. I am the cornea and contact lens resident at the SUNY College of Optometry. And this is a poster that I presented this past year at GSLS. It's called From Laceration to Lens, Scleral Lens Management of Ocular Trauma Resulting in Aphakia and Corneal Scarring. And just like Dr. Tucker mentioned, I have no financial disclosures. I can advance to the next slide somehow. There we go. And this is my poster. I want to give a huge shout out to Dr. Melissa Levine at SUNY for all of her help, not only on this poster, but throughout my school and now residency at SUNY. But getting into it, my patient is a 46-year-old female. She was referred into us for contact lens fitting. She does have a history of irregular astigmatism, secondary to kind of an unfortunate event. She had a bottle thrown at her and that glass shattered, leading to that glass entering her left eye. That led to a slew of problems for her, but among those, she had to have her lens taken out. No IOL was placed. She had laser retinopexy to seal up some retinal tears that occurred. She also had a pars plana vitrectomy. And then on the front of the eye, she had a laceration repair to close up the entry point of that glass. And I have a picture of her eye here. And you can see that scar running pretty much limbus to limbus. It makes sense, especially as it crosses through the visual axis, that vision would be reduced in that eye down to 2200. She's been getting around because her right eye has vision of 2025. So, like any contact lens specialist, I did the first thing we all think of. I went to topography. And this is the topography of her left eye. I'm going to ignore the right eye because we kind of left it as it was. So the technical coding was irregular astigmatism secondary to a laceration repair scar on this left eye. And if I blow these up, you will see, looking at this axial map first, if you look here, you can see that this area of steepening and then flattening on the nasal side or temporal side correlates with the scarring over here. And then looking at the anterior and posterior elevation maps, you can see areas of elevation that correlate on each side of the cornea, along with areas of depression. And that's just due to the trauma resulting in scarring that is contracting, leading to an irregular corneal surface. Also of note, her pachymetry values they remained average. So though the cornea topography looks almost keratoconic in some ways, because she's relatively average thickness, we know that this is the scarring that occurred. So we were thinking about what options in terms of what lens to go. So it's best to start really at the most simple option, glasses. Glasses are a great option for this patient because they provide a level of protection. She has one seeing eye without correction, so protecting that eye is going to be really important. So using something like polycarb glasses is going to ensure that she has the best odds of retaining good vision. They're also pretty low cost, and also there's no potential for any other things that could go wrong in the terms of contact lens related side effects. But as this patient is aphakic, there is a likelihood of anisoconia because she needs a high plus lens on that left eye and a near plano lens on the right eye. Those two image magnifications are going to be hard to overlap in her brain. And so she may develop some visual discomfort in glasses. So not the best option, but we jumped to the next simplest option, soft contact lenses. These come in a wide availability of parameters, so we can still correct her high plus needs. Typically, patients who wear soft contact lenses report greater initial comfort than other specialty lenses. And we do get really good tear exchange, high decay. We're going to get good oxygen going to that cornea. But soft contact lenses don't necessarily cover up all this corneal irregularity. So much of her visual discomfort may actually come from these elevations and depressions that we see on her cornea. And so a soft contact lens is merely going to conform to this corneal contour, and it may not give the best vision for this patient. So we skipped over it. And then we opted to go to a corneal GP. Corneal GPs have an even wider availability of parameters, so we can ensure that we can correct this patient. But what they have that soft lenses lack is that rigid front surface that provides that regular primary refractive surface that will allow to essentially correct for the distortions in her cornea. We do get really good oxygen permeability with every single blink. And when we put the lens on this patient, we got a best corrected visual acuity of 20/40. So we were stoked. And the patient was too initially, but then after we let the lens settle for a while, things changed. So this blue circle here is a simulation of her contact lens. And if you follow the animation, you'll see that it'll follow the anterior elevation map and go toward the depressions, and then in her case, down toward that inferior impression or depression. This led to that lens falling over her limbus, which is not great for the limbal stem cells, but also the optic zone of that lens was falling outside of her visual axis. So she was reporting a lot of streaking, a lot of glare, a lot of distortion. Her vision would fluctuate between 20/40 and 20, I don't want to read the line. So we opted to discontinue GP fitting and we moved on to a scleral lens because a scleral lens still has that rigid front surface that will provide that regular refractory power. But a scleral lens is going to be much more stable on eye than a GP because a scleral lens is not typically intended to move. But in her case, we're going to lose the oxygen permeability because if we remember, she's aphakic. And so she's going to need a high plus lens. And I actually have a picture of her lens on her eye. So This is the scleral lens, an OCT showing the scleral lens vaulting over the cornea. It's a little hard to read, but you can see we have about 150 microns of clearance over the cornea. We have limbal to limbal clearance. So all things that are ideal in a scleral lens fit. But if you compare that post-lens tear film with the lens itself, the lens is almost 2 to 3 times bigger than that clearance. So the lens also serves as a barrier to oxygen. This will drive the oxygen permeability of that lens system down. And so this is something that we needed to warn our patient about. And I think I have the actual lens thickness here. Yeah, 480. So it definitely is something that is going to be a barrier to oxygen permeability here. Of note, we decided to fit a small lens for this patient because she felt more comfortable in it, and we got away with using spherical edges. But her vision improved from even that 20/40 in a GP to 20/30 in a scleral lens. And just to wrap up with a few considerations here. So this is a quote from actually Teddy Roosevelt. I say this a lot when I'm working with students. Comparison is the thief of joy. If you think of the way that different specialty lenses feel when they're on your eyes, there's certainly a difference between different modalities. And if you're only wearing a lens in one eye, you have a normal eye to compare to. So that difference is going to be even more pronounced. The second point is just breathe. High plus lenses are going to have much thicker central thicknesses. High minus lenses will have either mid-peripheral or limbal thicknesses that are greater. So it's something that we need to be cognizant of and warn our patients that they should probably take breaks throughout the day of their lens wear just to make sure that that cornea is seeing oxygen throughout the day. And then the last point with this patient is it really does take a team. This patient currently still sees their retinal specialist who makes sure that their retina is staying intact, that laser retinopexy is holding everything in place. She still sees her corneal specialist just to check up on the scarring, to see if she's an eligible candidate for different procedures to hopefully reduce the irregularity. And then she sees the contact lens fitters. And it's important that we all communicate with each other to make sure this patient is receiving the best care possible. And with that, I think that is my poster. And I think I'm right at time. Anybody have any questions?
Dr. Pfeifer, thank you so much. I'm curious, this was an awesome case. Is there anything else you could have done to decrease the center thickness of that lens?
Yeah, so we thought about it. So we opted to fit this patient with a lens that is notoriously thinner than most lenses. And even that led to a 480 center thickness. What we could do, it would reduce the visual quality for the patient, or it could reduce the visual quality. We could steepen the base curve to have more central clearance and essentially bring down either the mid-peripheral or the mid-peripheral and the limbal zones to essentially create a plus tear lens in the actual tear film instead of the lens itself. There's a conversation to be had about, is that just changing one problem into another? But there is a potential that that would actually reduce some of that barrier to oxygen reaching the eye.
Perfect. Well, thank you so much. Guys, if you have any questions specifically for Dr. Pfeifer, please put it in the chat. But we will move on to Dr. Janna Pham. Thank you, Dr. Pfeifer.
All right. Hi, everyone. I'm Janna. I just want to start by saying thank you for having me and spending your evening listening to our cases. It's definitely an honor to be here. So I will be talking about my poster from GSLS named Sparking Hope, Scleral Lens Wear Post-Firework Injury in a Pediatric Patient. So starting with the case report, I had an 11-year-old male with complete limbal stem cell deficiency in the left eye secondary to a firework injury present for a doctor-referred scleral lens fitting. His pediatric ophthalmologist recommended a scleral lens fit given the status of his condition. He had gone through multiple different procedures, which we will briefly go through in a second, but things were just not looking great for him in terms of ocular health or vision. So his ophthalmologist thought maybe a scleral lens would help improve things. His mom did report that he had never worn scleral lenses or contact lenses in general before, and he is also not currently wearing glasses due to breaking them a few months prior. So his medical history was unremarkable. He didn't have any drug allergies, but his ocular history did consist of the firework injury that he had in that left eye a year ago, as well as leading to the symblepharon and complete limbal stem cell deficiency in that eye as well. The ocular surgeries he had to go through because of this injury were corneal debridement, symblepharon lysis, multiple amniotic membrane transplants, temporary tarsuraphy, symblepharon ring, and a limbal stem cell transplant. And he is currently still using Lotemax once a day in that left eye. So entering VAs uncorrected was 2015 in the right eye, but 2125 in the left eye, which pinholed to 2050. And slit lamp exam showed all normal findings on the right eye, but for the left eye, you can assume he had lots of abnormalities given his condition. Next slide, please. He had thickened irregular lid margins with inspissated glands, a reemerging symblepharon with 1 to 2 plus diffuse bulbar injection. He had neo with moderate peripheral haze 360, which is a clinical sign of limbal stem cell deficiency, and he had an irregular epithelial surface with cloudiness and also tear film debris. And looking at these slit lamp photos of his left eye, you can appreciate the conjunctivalization 360 around his limbus on this picture on the left-hand side, and then also the epithelial irregularity of his cornea on this right image there. So for his scleral lens fitting, we decided to go with a free-form lens given the irregularity of his cornea and sclera. So we used a scleral profilometer to obtain the data points, and then this is an image of his scans here in all 3 gazes. And we did trial a diagnostic lens in office just to get an over-refraction and to incorporate that in his ordered lens. So the assessments for this visit were complete limbal stem cell deficiency and symblepharon of the left eye, secondary to the firework injury, and also multiple ocular surgeries and transplants. We also noted how his vision significantly improved, even with just a diagnostic scleral lens in office. So our plan was to order the freeform scleral lens via the corneal scleral topographer and have him come back in 2 weeks for the dispense visit and INR training. At the dispense visit, we tried the scleral lens on with the listed parameters there, and he was able to immediately notice a significant improvement in his vision. I remembered initially putting this lens on his eye, and he just started blinking and looking around the exam room and saying, "Wow, I can see." His vision also improved with an over-refraction as well. And for the fit, we did notice a moderate amount of edge lift nasally with bubbles entering through that area. So we decided to order a lens remake that day. But in the meantime, given that mom had a few good INR attempts in office, we had him take the lens home to continue practicing INR with his mom and to come back in about 2 weeks for another contact lens dispense. And at that next visit, we trialed the second lens and noticed improved comfort and vision, even got him to 20/20 with this lens. And the fit also looked great. So we dispensed this lens and encouraged mom and patient to continue practicing INR at home and wear the scleral lens as much as possible, then come back in a few weeks for a follow-up. But because this patient does live out of state, we unfortunately have not had the chance to see him for his follow-up just yet. But we are hoping they are able to come back soon and that we're able to see the positive effects with scleral lens wear. Now we will briefly talk about some fears with fireworks. Just some general statistics. Firework-related trauma makes up 2% of all ocular injuries annually. They disproportionately affect children and males, and they usually occur around national holidays and at home. Firework-related trauma can lead to burns, both chemical and thermal, lacerations, corneal defects, complete limbal stem cell deficiency, as well as these other types of ocular injuries seen here on this pie chart. And focusing on limbal stem cell deficiency, normal functioning limbal stem cells are required for corneal transparency and epithelial integrity, but in limbal stem cell deficiency, there is a loss or deficiency in these cells, which results in the inability for the epithelium to repair and renew. This can lead to frequent epithelial breakdown, scarring, neovascularization, conjunctivalization, and even corneal blindness. So, how can we manage this ocular surface disease? There are multiple different treatment options: artificial tears, topical steroids, serum tears, transplants, but our main focus tonight will be on the scleral lenses. So, talking through scleral lenses and the use for it for limbal stem cell deficiency, scleral lenses, like many other corneal and ocular surface conditions, provide increase clarity and quality of vision, like it did for my patient, by creating a more uniform refractive front surface. It can also improve comfort for patients with advanced ocular surface diseases. It can also maintain ocular health by protecting the eye from mechanical trauma like blinking and creating an optimum environment. Scleral lenses are able to vault over the cornea and limbus and bathe the ocular surface with oxygenated solution. So this helps maximize the function of remaining stem cells in cases like limbal stem cell deficiency. And these pictures of this are of the scleral lens on my patient's eye. Something to note is freeform scleral lenses are recommended for highly asymmetric scleral shapes, like in my patient's case with his firework injury that led to lots of corneal and scleral irregularities, including the symblepharon seen there in that bottom right picture. And you can appreciate how well the lens edge lands on that area with the help of the freeform technology. So freeform scleral lenses are designed through scleral profilometry. It takes detailed scans and data points that allow clinicians to create a digital model of the corneal scleral shape that can then be used to construct a highly customized scleral lens. Again, this is indicated in patients with significantly irregular corneas and scleras, so it worked and helped greatly in my patient's case. And it can also decrease chair time and the amount of trial lenses needed for a complex specialty lens fit as well. So it's just a great innovative practice tool all around for practitioners. So to conclude my presentation, some main points to consider are surgical treatment options may be necessary in firework-related ocular injuries, but no matter how many procedures are performed, decreased vision can still persist, which is where scleral lenses can help significantly. Scleral profilometry should be considered when faced with challenges of fitting complete limbal stem cell deficiency and a highly asymmetric scleral shape. Freeform scleral lenses are a beneficial tool eye care practitioners should consider, as it can enhance vision, comfort, and maintain ocular health in these patients. And these are my references. Thank you again.
Thank you so much, Dr. Pham. I totally agree with your choice on using the freeform design. Would you make a comment though on why you guys chose the freeform versus like a prose design or like the impression-based designs?
Yeah, so we didn't go with the prose design because unfortunately we are not a prose provider. And then we didn't go with a more specialized like eye print type of design because from my understanding for eye print, to do the impression, you have to kind of keep like a steady gaze. And for him, since he's only 11 years old, has never had anything even touching his eye, he was already like finicky to begin with. So we didn't think that would be a good option either.
I agree. Would you say just cost as well? Is the freeform design less costly than the other two? If
Yes.
cost is an issue for the patient.
Yes, significantly. And especially for his case, since he was coming out of state, it was already hard to get coverage in that sense as well.
Okay, thank you so much. All right, Dr. Valery Medina, you can come on camera. We are ready for your presentation.
Thank you. So I'll be talking about corneal rehabilitation with scleral lenses in the setting specifically of exposure keratopathy secondary to longstanding facial palsy. So our case is the case of a 38-year-old female who was referred to the medical contact lens service by oculoplastics for a scleral lens fitting of the left eye. She was experiencing chronic dryness, exposure, and significant reduction in vision and quality of life. Her medical history included a left-sided acoustic neuroma, which was resected in 2008, but unfortunately during the resection, her cranial nerve 7 was injured, and so she has a facial palsy that has been causing chronic keratoconjunctivitis and recurrent corneal infections. And then here we have a video of our patient's blink. As you can see, she is a grade 4 cranial nerve 7 palsy with poor passive blink. She does have a good Bell's phenomenon as her cornea tucks under the upper lid. She has about a 3 millimeter lag with closure, 1 millimeter lag with tight closure, but she's wearing her scleral lens, and as you can see, her blink is unchanged here. So before she started scleral lens wear, she had a very compromised corneal surface. As you can see, she has diffuse staining with epitheliopathy in the central visual axis, but she didn't have any epi defects. In white light, you could see that infratemporally, she was starting to scar a little bit with some mild sub-epi scarring. All of this is a consequence of her exposure and inability to maintain a uniform tear layer on the ocular surface. So when managing exposure keratopathy, frequent lubrication is generally the first line of treatment and should be enough in mild cases. Our patient was using artificial tears every 10 minutes. So not only is this expensive, but I don't know if you've ever tried to put artificial tears in every 10 minutes as you're working on the computer. It's quite unsustainable. But she had tried a lot before I met her. One of the things she said that gave her the most relief in symptoms was the gold weight, but it did start to cause a noticeable ptosis, and so she chose to have it removed. She then tried a medial lower lid elevation or partial torsorrhaphy. It's a bit unclear since she had this done while she was still living in Mexico City, but she said it also helped to improve her symptoms, although it affected her cosmesis and the sutures came undone, so they're no longer present. She also tried bandaged soft contact lenses, but she thought this made her symptoms worse. So as we know, bandaged soft contact lenses are used to protect the cornea from the eyelids and lashes, and they're worn for an extended period of time until removed by a provider. And because of the extended wear of bandaged soft lenses, we often use a prophylactic antibiotic to reduce the risk of infection or corneal ulcers. But this same reason is why we don't like to use them as a long-term solution, because of the change to the ocular surface flora with long-term antibiotic use. On a similar note, scleral lenses can protect the cornea from the eyelids and lashes, but additionally, they lubricate the surface with their fluid reservoir, as you can see in the picture over to the side. So ideally, they're worn daily for the long-term management of chronic ocular surface disease and removed at night. Overnight wear is only recommended in very specific situations, and we call this 12-12 wear, where 2 scleral lenses are used, one during the day, one at night, and you switch between them every 12 hours. As one sanitizes, you wear the other. Now, we still do use a prophylactic antibiotic in the bowl with these, but it's difficult to compare them to soft lenses because scleral lens infection rates are less documented and currently still being investigated. The main difference that I did want to highlight here is the presence of the fluid reservoir or the tear layer, because in theory, soft contact lenses should have a very thin layer between the cornea and the lens. However, when the eyes are dry, there may be no tear layer present between the cornea and the lens. So in situations like this, a blink could create shearing forces between the adherent lens and the underlying cornea, which could detach newly migrated epithelium, kind of like in your classical recurrent erosions when the eyes are first opened upon awakening. And this is likely why our patient did not like bandaged soft lenses, because of the friction between her dry cornea and the contact. And here we can see our patient's progression as she starts to wear her scleral lens more. You can refer back to the original picture where at the dispense, she had a compromised corneal surface and poor vision or reduced vision. After being fit with a 15.8 millimeter scleral lens, she had now constant lubrication and protection. So with 4 weeks of scleral lens wear, her vision improved to 20/25 -2. She reported an improvement in comfort and reduced need for artificial tears. So the only complaint she did have was that the scleral lens surface did get dry. And this is a very common complaint that we get with scleral lenses. Another complaint we get is increased deposition of mucus and protein on the surface of the contact, where deposits on the surface of the lens can cause issues with comfort and lens stability and even reduce vision. So our plan was to add hydropeg coating to the next scleral lens. After 8 weeks, she came back and her comfort had improved even more with the hydropeg coating. And hydropeg is a 90% water-based polyethylene glycol-based polymer that is bonded to the contact lens surface during the manufacturing process. And studies suggest that hydropeg improves surface wettability, lubricity, deposit resistance, tear film quality, and subjective comfort, according to the manufacturer Tangible Science. So not only did her comfort improve, her vision, she had a 4-line improvement in vision over 2 months with 12 hours of daily scleral lens wear. And not only that, but she was no longer dependent on artificial tears every 10 minutes. The one complaint that she did end up having about scleral lenses is that her left eye looked huge compared to the right eye. And it is well documented in the literature that scleral lenses can have an effect on eyelid positions and can be used as a non-surgical and non-pharmacological treatment of eyelid ptosis. We can do this by manipulating the center thickness, sagittal height, and diameter of the scleral lens to either increase or decrease the eyelid to lens interaction. Now, in our specific case, we couldn't decrease her diameter because the original goal was to protect her cornea and limit exposure. So we couldn't decrease that, and her sag was adequate at this point. So as we commonly do, we gave her 2 choices. Option 1 is let's fit the right eye so that there will be a little bit more symmetry. So you can see in the top picture where she just has the unilateral fit and it's a little bit more asymmetrical. And in the bottom, we put in a scleral lens on the right eye and the left eye. And you can see that there's a little bit better symmetry between the 2 eyes. I do want to point out that without scleral lenses, she does have a 0.5 millimeter difference in her MRD1. So her right eye measures 4 and her left eye measures 4.5. So I think we just accentuated a small difference here, but I would like to highlight this case series where scleral lenses were used to improve ptosis in patients. The main idea is that the bulk of the lens, it acts as like a crutch for the eyelid to kind of prop the eyelid up and allow for increased palpebral aperture size. Now, there are variable effects, but we can see in this patient that she had a 5 millimeter improvement in her eyelid ptosis. And then next images. And in these, we also have a little bit of a variable effect. I would like to highlight figure 2. This is a gentleman with advanced ALS who had difficulty opening his eyelids due to progressive muscle weakening. And because of his poor ability to open his lids, he had difficulty communicating with his augmentative and alternative communication device, thereby profoundly impacting his quality of life. And so with scleral lenses, he was now able to open his eyes and communicate. So don't forget about scleral lenses as an improvement for ptosis. But our patient ultimately ended up choosing the pharmacological route. We ended up prescribing Upneeq, which is an FDA-approved drop for the treatment of mild ptosis. It targets Mueller's muscle and increases aperture size by at least 1 millimeter. The effects last about 6 hours, but our patient planned to just use it for special occasions for her right eye. So this was enough for what she wanted to achieve. And I actually don't think she's filled the prescription, so she might just be happy as is. But in conclusion, scleral lenses can provide constant protection and lubrication to the cornea and serve as a great treatment for corneal healing. They can improve comfort, vision, and quality of life, and can be considered for patients with facial palsy. So a referral for medical contact lens evaluation could help prevent ocular complications. And thank you to the hosts for having me and to my mentors for the support.
Thank you, Dr. Medina. That was great. So back to this. Oh, I'm echoing. It's okay. So back to the options for your exposure keratopathy. Do you have a recommendation on a specific antibiotic, or do you have a protocol there when you're coupling an antibiotic with a scleral lens or a bandage contact lens?
Yeah, so my preferred one, specifically for bandage lenses and scleral lenses, is moxifloxacin or Vigamox because of its self-preserved nature. But I know that we often use ocufloxacin with the bandage lenses.
Perfect. Thank you so much. There's several questions. We'll try to get to more of them at the end. Thank you, Dr. Medina. All right. Last but not least, we have Dr. Matthew McGee.
All right, so bringing in the rear. So my name is Dr. Matthew McGee. Thank you to the Scleral Lens Society for having me. And my poster at GSLS was Reclaiming Vision, Scleral Lens Fitting After Acanthamoeba Infection. So I have no disclosures. So my patient was a 54-year-old female who presented for an evaluation due to decreased vision and severe right eye pain. So these symptoms started 2 to 3 months before she was seen at our office, and she was diagnosed by an outside provider with suspected HSV keratitis and neurotrophic keratitis. And her current symptoms, even when she presented at the 2 to 3 months after the onset, was blurred vision, stabbing pain, tearing, and light sensitivity in that right eye. And before she even saw us, she had tried a myriad of therapies, including antibiotics, steroids, immunomodulators, antivirals, and even amniotic membranes. And she really didn't get any relief with any of those therapies. So when we saw her initially, she was hand motioning in her right eye and had 2 to 3 plus injection in that eye with diffuse punctate epithelial erosions, central circular anterior stromal scar, and surrounding haze, and an overlying epithelial defect. And this is how her right eye looked. So it's really just a really bad, red, angry eye. And you can appreciate that haze on the picture on the left-hand side and that epithelial defect with that sodium fluorescein and our cobalt blue filter. But upon asking her further questions, she did admit to having soft contact lens abuse. She wore monthly disposable soft contact lenses and frequently wore them past their replacement date, didn't clean them very much, and often slept in these lenses. So that, coupled with her not having any improvement with conventional therapy, prompted us to culture her. And we did a culture for acanthamoeba, bacterial culture, as well as fungal culture, and it came back PCR positive for acanthamoeba. So acanthamoeba is a free-living unicellular protozoa that's found ubiquitously in freshwater and soil, and it has a trophozoite form that's metabolically active and a resistant cyst form. So acanthamoeba is primarily associated with soft contact lens wear. About 85% of acanthamoeba cases are associated with contact lens wearers, specifically with patients who have poor contact lens hygiene, use tap water, or swim in their lenses. So 1 in 25 cases per 10,000 contact lens wearers do get acanthamoeba keratitis, and 1.49 to about 2 cases per million in the United States happen every year. So acanthamoeba keratitis is a progressive and chronic disease. So these patients will come in, we usually hear that it's disproportionate pain that doesn't quite equal their clinical signs. But this pain can vary from foreign body sensation all the way to severe pain. And they usually have tearing, redness, and decreased visual acuity. And some of their early signs are irregular epithelium, pseudodendrites, radiokeratinitis, and an anterior stromal ring. And then as it progresses, it can have late signs as bad as lambitis, scleritis, uveitis, corneal melt, and perforation like you can see in that picture. So Though some of those signs and symptoms are a little vague and a little non-specific, so acanthamoeba is usually misdiagnosed initially and can go on for quite some time, like it did in our patient. So one thing to think of is with herpes keratitis, they can look a little bit the same because of their irregular epithelium early on, but we attempted treatment with antivirals and she didn't have any improvement. Another thing to think of, especially with poor contact lens hygiene, is fungal keratitis. Both of them can present with ring infiltrates, but we did our cultures for fungal and they came back negative as well. And then the last thing, especially with poor contact lens hygiene that we think of is Pseudomonas. But our patient was previously treated with topical fluoroquinolones and she didn't have any improvement and we had a negative bacterial culture. So that's how we landed on acanthamoeba. So treatment for these patients, it's imperative to early diagnose these patients because that would lead to their better visual outcome when the disease resolves. But because they have those vague signs and symptoms, average delay of diagnosis is 50 days. So that can be really visually debilitating to our patients. If we catch it early on, it's really just localized to the epithelium, so we can debride it. But if it progresses into the stroma, then it becomes a little bit more challenging to treat. So we treat them with PHMB and chlorhexidine on a 3 to 6 month basis. So for our patient, we decided to treat them with moxifloxacin because of that epithelial defect, chlorhexidine and PHMB quite frequently, due to them treating the acanthamoeba, cyclopentolate for pain, and valcyclovir. So our patient, we treated her on about a 3 month basis and we're able to titrate down the PHMB from every hour to every 2 hours and then to 4 times a day. But then we unfortunately lost her to follow-up for about a month or two. And when she came back, she still had her regular epithelium and a pretty red and angry eye. So we had to put her back on chlorhexidine for 6 times a day for a month and then titrate her down back to 4 times a day. And then she was able to be seen for us for a scleral lens evaluation. So she came in for a scleral lens evaluation because after the infection subsided, she was still counting fingers at 3 feet in that right eye and still had mild irregular epithelium with an overlying central scar, faint neovascularization, and stromal haze. So we utilized the scleral lens to improve her vision and to minimize the effects of her scar and subepi haze. So you can appreciate that scar on the right side of the picture and some of that set that behaves, but you can appreciate it a little bit more on her tomography maps. On the axial map, you can see that large area of flattening, and then she has those irregular spots on her posterior and anterior elevation maps as well. So we diagnostically fit her into an 18 mm scleral lens initially. And then in her left eye, we actually fit her into a daily disposable soft lens as well. We were really reluctant to do so, but she really refused to wear glasses. So we really just preached compliance with that eye as well. So on her initial fit, we ended up having about 425 microns of clearance on that lens, and she had a little bit of fogging, and it was a little bit of inferior decentration. So we decided to decrease the sag and tighten the haptics by about 100 microns to center the lens a little bit more. And with that, she was a lot more happy with her comfort in the lens and a lot more happy with her vision. So her final visual acuities through that subepi haze and that resulting scar in the right eye was 20/40 plus 2, which is a pretty significant difference from counting fingers. And in her left eye, she was 20/20. So just some things to think about, especially for us as contact lens providers, is there should be a high clinical suspicion of acanthamoeba keratitis if a patient is primarily wearing contact lenses and has a history of noncompliance. Corneal cultures are imperative to do, especially for these patients who are pretty refractive to conventional treatment, and it's better to do it early so that we can get the most favorable visual outcome. And then scleral lenses are indicated for these patients after the active disease process has subsided to provide the best visual outcome over their resulting scars and subepithelial haze as well. And thank you.
Thank you so much, Dr. McGee. I have a couple questions for you. So as we all saw in your photos, acanthamoeba can be visually debilitating and it can be quite unsightly, the scarring at least. How often do acanthamoeba patients require a corneal transplant?
According to literature, only about 25% of them require a transplant. And that's because we have the technology with scleral lenses and GPs. They can help give them a better visual outcome without having to go down that long road of recovery for a corneal transplant.
Awesome.